So what I wanted to do with my 15 minutes was present primary mediastinal large B-cell lymphomas, and because there is a lot of controversial areas in this topic, what I wanted to do was try and convince the audience that this is a separate subset of lymphomas, that it's not the same as diffuse large B-cell lymphomas or another category of diffuse large B-cell lymphomas. It is a distinct subset, and we've got a lot of genetic and otherwise evidence to say that it is a different subset which needs its own treatment and has its own prognostic implications. The standard of care in primary mediastinal large B-cell lymphoma used to be R-CHOP, but the infusional epoch therapy has recently gained a lot of interest amongst physicians who treat lymphoma. And that's because of one of the trials which was presented in 2013. And since then, things have changed a lot. And it's primarily because this is the sort of lymphoma that presents in younger individuals, especially females, and we're trying to get radiotherapy off the shelf or off the treatment plate here. So we start with some of the epidemiological data, and it's not a very common one. It is only 7% of all diffuse large B-cell lymphomas. 7% of all diffuse large B-cell lymphomas are what primary mediastinal lymphomas are. And when they do happen, they happen in predominantly younger population, and they're all and there is a lot of female preponderance in this age group. The median age group for this sort of lymphoma is 3rd to 4th decade, as compared to the diffuse large B-cell lymphomas, which are much older, which present in a much older age group. So they arise from the thymic B cells, and which is why they're kind of extranodal aggressive B-cell lymphomas. And as I said, they're a distinct entity. They're not a part of, not same as diffuse large B-cell lymphomas, just present in the chest, which is a separate entity on its own. You can see large size, cytologically atypical lymphoid cells with abundant pale cytoplasm in the background. And then a histological diagnosis is not very difficult in this form of lymphoma. So if we look at the age distribution, on the left is diffuse large B-cell lymphoma, activated B-cell type, and the GCB type, and on the right is primary mediastinal lymphoma. As you can see, median age is much younger, and majority of patients that present with this form of lymphoma are younger in the age group. So when you're presented with a mediastinal mass, you've got to make sure that one of the top three diagnoses are the classical Hodgkin's lymphoma, which again present in the same age group, but from an immunohistochemical point of view, the Hodgkin's lymphomas, as you know, are 15 and 30 positive and 20 negative. On the other hand, the primary mediastinal lymphoma is 20 positive and occasionally 30 positive, occasionally has weak CD30 expression, but it's 15 and 30 negative usually. And of course, the similarity between the two is that the JAK-STAT and the NF-kappa B pathway is upregulated in both the malignancies. But between these two malignancies is the mediastinal gray zone lymphoma, which is a newer entity, a relatively newer entity. And as you can see, again, the other way of looking at mediastinal gray zone lymphoma is that it is an entity which is somewhere in between the primary mediastinal and the nodular sclerosis Hodgkin's lymphoma. So if we look at genetics, and you can see this genetic spread here, the molecular diagnosis of primary mediastinal B-cell lymphoma, and on the left is the gene expression. So the molecular diagnosis of this type of lymphoma is entirely different from the diffuse large B-cell lymphomas. As you can see on the left, the expression of the top panel of genes is completely red in the PMBCL category, which is left, and green in the diffuse large B-cell category, which is on the right. And you can see that the bottom panel is entirely different, and you can see the bottom. I put all the diagnosis at the bottom so that you can make out the difference between the two. And now if we primary mediastinal lymphomas, they look much more similar to Hodgkin lymphoma as compared to they look to the GCB or non-GCB type of diffuse large B-cell lymphomas. So hopefully the slides are now moving with my presentation. Now, if you're faced with a primary mediastinal lymphoma, the top 4 diagnoses that you need to consider is the diffuse large B-cell lymphoma, which has got a mediastinal mass, a mediastinal gray zone lymphoma, which is a relatively new entity, which looks histologically and immunohistochemically somewhere in between the diffuse large B cells and the Hodgkin's lymphoma. And then there is the primary mediastinal B cell lymphoma. And finally, there is the classical Hodgkin's disease. So a mediastinal mass, either of the 4 diagnostic possibilities are there. And it is important to distinguish all the 4, because what we need to do is, because they are very, very different in terms of progression, very different in terms of prognosis. And of course, the treatment of all of these lymphomas is different. And we've got to choose an appropriate regimen based on the age of the patient. Age, performance status, etc. So making a diagnosis usually is not very difficult. We take a biopsy from the mediastinal mass and look at the tumor morphology. We run an immunophenotype, and as I said, CD20 positive, 15 negative, 13 negative usually would be what primary mediastinal lymphomas looks like. Sometimes they can have weak expression of CD30, but then there are other markers in case we get into CD30 or a MAL protein, sometimes even a PDL1, to differentiate between the primary mediastinal B-cell lymphomas and the Hodgkin's, and sometimes even the diffuse large B-cell ones. They generally express the pan B-cell markers, and in imaging, one of the clues is with the primary mediastinal lymphomas, they are generally localized to the chest. They don't go outside the chest, which means it's usually a stage 2 disease. So the clinical presentation usually comes with a huge mediastinal mass. There can be a superior vena cava syndrome, and you need to be aware of that. Patients can present with facial and arm swelling and dyspnea, especially dyspnea which gets worse with lying down and with positional changes, because there is additional compression because of gravity, and they also present with cough and chest pain. So the clinical presentation is variable, but sometimes generally it's stage 1 or 2 diseases. CT scans would pick up a huge mediastinal mass, usually a conglomerate of a lot of lymph nodes which are stuck to each other. If we do a bone marrow, which we generally end up not doing, the bone marrow is not involved, and because of their young age and limited disease, they are generally low in IPI. So a word of caution, we have to make sure that it's not a systemic lymphoma with mediastinal involvement, and even more importantly, it's not a nodular sclerosing classical Hodgkin lymphoma, and sometimes histologically they can mimic each other very well. Gray zone lymphoma can only be picked up with immunohistochemistry, and it is mandatory that we realize that and ask our pathologist to run a proper immunohistochemistry on all our patients. So the problem with this type of lymphoma in choosing a treatment option was and still is that they are so rare that we don't have a lot of evidence to back our treatment decisions. And to that end, all of us used to use R-CHOP, and because they were in the mediastinum and the disease was generally bulky, we used to add radiation. But as you can imagine, that becomes a problem when they present in a younger age group, and especially they are females, and because females can have increased risk of breast cancer with radiation, there was an urgent need to get radiation off the plate for the treatment of these diseases. So the trial that first looked at primary mediastinal lymphomas was the MINT trial. If you remember, this is the MabThera international trial, which brought in rituximab, that cemented the position of rituximab in aggressive B-cell lymphomas. And what they did was they looked at a subset of patients and did a subset of 80 patients who had primary mediastinal lymphoma. So the ones that have R chemo, did much better, and especially had you can see the 3-year event-free survival was 78 versus 52%, and overall survival was 89 versus 78%, and there was a trend towards improvement with rituximab. So rituximab had cemented its position not only in the aggressive B-cell lymphomas, but also in this category of lymphomas. So the next trial was the UK NCRI ARCHER 14 versus 21 trial. And in this trial, they did a subgroup analysis of 50 patients with PMBCL. And this is the first trial that introduced the concept of intensification, and the concept of intensification in this category of a subset of lymphomas. And it generated, so obviously ARCHER 14 and 21, if you remember, was equal in all other DLBCLs. So ARCHER 14 became another option for most people who wanted to get through treatment quicker, but it had a lot more cytopenias. But in this subset of patients, you had 50 PMBCL patients, and those 50 did much better with ARCHER 14 as compared to ARCHER 21. So this is the trial that really brought in the concept of intensification, and if you intensified chemotherapy, that you could get better results in this subcategory of patients. So to that end, people wanted to do more intensive chemotherapy for this subset. This subset had its own peculiarities where it could tolerate intensification very well, especially infusional protocol. So an infusional protocol called dose-adjusted EPOCH was introduced, and this was the original article and the study from NCI group, which was published in New England Journal, and they looked at the dose-intensified infusional chemotherapy program plus rituximab, and the results were published in NEJM. And as you can see, event-free survival in the NCI cohort versus the Stanford cohort, and the NCI cohort was prospective, and the event-free survival was almost 93%, with overall survival well above 90% at a median follow-up of 63 patients. And the Stanford patients, which were only 16, but the interesting thing was that the event-free and overall survival there was 100%, and even at a follow-up of 37 months, overall survival remained 100%. So this trial, one of the major problems was if you give infusional doxorubicin and keep escalating doxorubicin and etoposide, would it have effect on your cardiac ejection fraction? And as you can see, these are plots of ejection fraction compared to time, orange on the top and green at the bottom, before and after chemotherapy. And as you can see, there's very little difference between before and after ejection fraction. So the worry that the ejection fraction would drop with such intense protocols wasn't really substantiated. So the baseline characteristics of patients and predominantly females, predominantly younger patients, predominantly very little extranodal disease, and a very little stage 4 disease. So that cements the position that this disease is very different to the other diffuse large B-cell lymphomas. So the conclusion was dose-adjusted EPOCH, although this was a single-arm trial with only 50 patients, and some of them, and 16 patients being retrospective, but it gave us enough to say that dose-adjusted EPOCH was something that could obviate the need of radiotherapy in this category of patients. So a retrospective analysis was done. And it was a multi-centric retrospective analysis. In most of the centers were in North America, and 156 patients were pulled, all adults and children, and all had received dose-adjusted EPOCH between 2005 and 15, and had reached level 4, and this one showed that a progression-free survival of 87% and an overall survival of 97% was achievable for this form of therapy. And since this is retrospective, This is real world data, and you can extrapolate that to say that this is something that which we can achieve in our clinics with a very high rate. So MD Anderson did its own retrospective analysis, and in this retrospective analysis, they compared they compared various types of chemotherapies, and R-CHOP, HCVAD, I don't know what that is, and R-EPOCH were compared. And the interesting thing is that all of them gave a very high response rate, but the thing to note here is that R-CHOP, majority of patients who had R-CHOP had also had radiotherapy to the chest, although only 20% of EPOCH had radiation. So although high overall and event-free survivals achievable, there was no statistically significant difference between R-CHOP and EPOCH. Another retrospective analysis, 132 primary mediastinal lymphomas, 12 North American centers, and he said you could achieve a high CR rate with the dose-adjusted EPOCH, but at the same time toxicity was higher. So there was no overall survival difference, which goes to say that again, there is mixed evidence that we're getting here. Obviously, the only answer would be by getting a head-to-head trial between the two chemotherapy agents, but we don't have that answer yet. So another retrospective study, this time 15 years, 124 PMBCL patients, R-CHOP versus R-CHOP with radiation, and dose-adjusted EPOCH without radiation. And again, there was no difference found between R-CHOP radiotherapy and dose-adjusted EPOCH, although R-CHOP was inferior. So the evidence is a bit mixed, but the single-arm 2013 trial showed that our EPOCH was giving us much higher response rates than we expected from R-CHOP, which is why, as you can see from all these centers which were doing R-CHOP before 2013 April, when the trial was published, had changed over, and very few centers remained with R-CHOP, so most of the centers changed over to EPOCH. So for future, the trial areas, now that we understand a lot of disease biology about this, we know that JAK-STAT signaling pathway is involved in the pathogenesis of this disease. The NF-kappa B pathway is abnormal. We can target the JAK-STAT pathway. We can target the NF-kappa B pathway with bortezomib or proteasome inhibitors. There are certain targetable surface markers. So brentuximab, the anti-CD30 antibody, and of course, as Roshan said, we've got CAR T cells and we've got rituximab to target CD20, CAR T cells to target CD19 protein, and the PDL axis also is abnormal. So we can use PDL1 inhibitors, and these are all the research areas, and I'm sure we're going to see a lot of this coming in the near future. So to conclude, I just want to say that this is a different biological entity. It's closer to Hodgkin lymphoma as compared to the diffuse large B-cell lymphomas. Dose-adjusted EPOCH is a feasible treatment, can be done, and it's a treatment that we can safely and easily deliver in our inpatients. And because this is a category which is younger and which are females, we have to try and avoid radiotherapy to the chest, although R-CHOP with radiation remains a viable option. And for centers who can't do infusional protocols for whatever reason, it does remain, R-CHOP with radiotherapy remains a viable option. So with that, I want to thank you for your attention and for listening. And if there are any questions, I'm quite happy to answer them. So I'm going to stop my screen.
Before that, Nitin, let me take this opportunity to thank you for that excellent lecture, very insightful, very educative, and you have dealt the entire issue from a very practical standpoint as well. I thank you indeed for this wonderful lecture.
Thank you, sir. Thank you.
Nitin.
Yes, Subhash.
So dose-adjusted epoch, and how many dose escalations have you done so far? What's your maximum one?
So we start with the level 0, which is the 10 milligram of doxorubicin and the rest of it. And we are able to, I mean, the younger ones, we are able to go to level 2.
Okay.
So that's the maximum you can go. Or you can go to -1 and -2 if you're not.
Yeah. I mean, the maximum we could do was probably 1, and we escalated to 1.5. I don't know. There is no 1.
I don't think you can do 1.5, can you?
Yeah, but we did try doing it. But from all the studies which we can, I think you can safely, if you're not able to escalate beyond 1, apparently that's okay. But the most critical component is probably the infusional chemotherapy.
Yes, that's right. That's right.
That's the 90 infusion apparently is the most useful one. Is that what you found? And the biggest problem in the dose-adjusted epoch or most of the lymphomas as such, I mean, apart from the Hodgkin's, is the response assessment PET, which happens to be a major problem in many of those mediastinal lymphomas.
Yes, I'm glad you brought up the end treatment PET, because the false positivity of the end treatment PET is fairly high for mediastinal lymphomas. And again, you need to have a very experienced PET physician and probably see the PET scan yourself, have a low threshold for a repeat biopsy, or maybe even sort of repeat the PET in 6 to 8 weeks. Because mediastinum is such an area, it's very difficult to interpret. Plus, there's a lot of inflammation going around, especially after radiation. So the false positivity is very high with the PET scan, especially. So that is one of the very controversial areas, is the end treatment PET scan. Now, I didn't include that in my talk because I didn't want to confuse the issue. But the end treatment PET is one of the areas that needs a lot of research in the future.
Nitin, can you hear me?
Sir, I can hear you. Thank you for joining.
Thanks, sir. Just want to ask you, someone who has gone on a 0 level, or someone has gone on to level 1 or 2 or 3 or whatever levels, is there any difference in the outcome has been analyzed? The people who could achieve this level? Or...
No, I think it's more important that you give the infusional chemotherapy. Now, the point is, I don't think we've analyzed the difference. We've not even reached to the stage where there has been a head-to-head trial between EPOCH and R-CHOP. The ones that I showed were retrospective analysis with their own confounding problems. So there is no head-to-head trial. I mean, forget about reaching levels. That kind of evidence is just not available to us.
No, but is there any retrospective try of this? The reason is how much to push for. So you are always worried about the relapse and at the same time the tolerability. So how much do you push it? You can push it for the level 2, and you can treat it like a AML, put it into the ward and do it, whether it is required.
I know, but so again, there is no evidence to say that the higher you go, the more you get. But again, I think we shouldn't push too much, because there is the nadir neutrophil count and the nadir platelet count that you've got to make sure that you don't cross, and to make sure that the febrile neutropenia, growth factor usage, all that we have to be very careful about anyway.
Sure. Thanks.
So there are 2 questions from the panelists. I'm just going to read those from the audience. What about overall survival and progression-free survival between EPOCH and R-CHOP for primary mediastinal? Yeah, so I think we've answered that anyway. So one of the questions is, what is the treatment choice in HIV patient with PMBCL? And to COVID-19 patient with PMBCL. So gosh, that's a very difficult one. So HIV patient with PMBCL remains the same as, to the best of my knowledge, remains the same as HIV patient with aggressive non-Hodgkin's lymphomas, which means that if the HIV is in good control, you can use rituximab. But usage of rituximab in uncontrolled HIV becomes a big problem, and infections increase quite quickly. So I think we should not use rituximab in that area, in that situation. But of course, try and get the HIV under control as soon as you diagnose it. Once you've got a good CD4 count and a low viral load, then rituximab can be used. The COVID-19 pandemic, now I don't know, I mean, COVID-19 pandemic with PMBCL, that is a different, that's slightly tough question. I would, no, if you ask me, I would, sorry, sir, you've rescued me.
We had one patient who was a young guy during our DIPOC. He had a COVID, so he went to the COVID ward. A lot of toxicities, so he had a significant problem. He was already on DIPOC, and that was a last kind of a cycle. But I think probably one option is to go on RCHOP and rather than going intensive on the DIPOC. That's my suggestion.
Yeah, but I guess the question is, would you start DIPOC if somebody was to diagnose?
Probably. No, if it's clear, if lungs are clear, CT scan is normal, the HRCT is normal, then probably yes. But someone has a lung abnormality, probably, that's my opinion. Go low.
I don't think there's a right or wrong answer here.